Hello and welcome. I'm Steve Clemens. I'm editor-at-large of The Hill. Thanks for joining us for Diabetes and the Future of Healthcare Reform. This is going to be a deep dive into what the future of healthcare could look like for patients with diabetes. I'd like to thank our sponsors, the Diabetes Leadership Council and the Diabetes Patient Advocacy Coalition, for their support of today's event. As the next 4 years of healthcare policy take shape, it's a crucial moment for the 1 in 10 Americans, that's 1 in 10, living with diabetes for whom reform is not just a talking point, it's a lifesaver that could mean easy access to quality care. Are there improvements that can be made to Medicare or to Medicaid and to commercial insurance? How can we restructure our nation's healthcare system so that it works for everyone, particularly those with chronic conditions? We're going to be asking these questions and more. But before we get underway, a few housekeeping notes. First, I hope you tweet us at @TheHillEvents using the hashtag #TheHillDiabetes. Not too complicated. We're going to broadcast live, and we'll be taking your questions throughout the program. Just tweet them in, email them. My team will bring them in. As with any live stream, you could experience occasional trouble with the video. Refreshing the page should, in most cases, fix the problem. My first guests today have spent their careers working to ensure access to quality care for patients with diabetes and are joining me today for an in-depth discussion of what a reform of commercial insurance could accomplish. Dr. Satish Garg is professor of medicine and pediatrics at the Barbara Davis Center for Diabetes at the University of Colorado School of Medicine. It's a mouthful, but he's great. Dr. Garg is also the editor-in-chief of Diabetes Technology and Therapeutics Journal. And Cynthia Rice is chief mission strategy officer for JDRF, a global charity funding type 1 diabetes research. Cynthia is responsible for JDRF's advocacy to government and healthcare policymakers. Welcome to you both. Thanks so much. I mean, Cynthia, let me start out with you because I know JDRF covers a lot of things, but one of the things that really struck me in my dive into this subject, and I just want to be honest with everybody, you know, just scratch the surface of your friends. It's out there in your family, in your friends, in your neighborhood. I myself was a bit ignorant of the footprint of diabetes around me, and I just want to be open about that. But juvenile diabetes, undiagnosed diabetes, is huge. You know, when you look at 1 in 10, 34 million Americans, 7 million not diagnosed. And I'm just interested when it comes to thinking about moving this into a place, particularly reforming the cost side of this. Reforming the cost side also means getting more people in the terrain of care. So what would be the most important bits of this that you'd like to move?
Thank you. It's great to be here today. Look, unfortunately, too many Americans have difficulty accessing the drugs and the devices they need to manage this difficult disease. Fundamentally, diabetes care is preventive care. If people have the right care, then they can avoid emergency room visits and avoid having to have devastating long-term complications.
And so I get that, but I think the part of it is, you know, from a foundation perspective, what elements of the cost curve are you trying to adjust? I know that, and I don't know if you've seen it, but I've been reading over the last couple of days, the Democratic Leadership Council has this, you know, consensus set of findings, for instance, that it's talked about. You know, there are, many different dimensions of it, but part of it is, making sure that pre-existing conditions aren't lost, making, $1 is covered, those kinds of dimensions. What on that front do you think matters in your priority of concerns on the cost side?
Right. I mean, what matters the most is that people have access to insulin and people have access to the devices they need to dose insulin effectively. And so that means that health plans and employers should be providing those at low, predictable, out-of-pocket costs so that people with diabetes can access them. I mean, unfortunately, more and more Americans are in high-deductible health plans. And that means that they have to spend thousands of dollars out of pocket before their insurance covers any of their diabetes care. So, how are they supposed to stay out of the emergency room in that sort of circumstance? So, we need companies and we need health plans and we need employers and we need the government to really treat insulin and the devices to deliver it as the life-saving therapies that they are.
Thank you. Dr. Garg, I don't know if
Can I add something to this, which is
please go ahead.
You asked. There might be a simple answer. There is a bit of greed involved from all the parties, both the commercial payers as well as the companies who manufactured. In all fairness, I do a lot of studies for all the companies, but I have no stocks in any of the companies. But here's a very good example. If patients didn't have insurance and they wanted to buy a vial of insulin, it normally costs $400 to $500. The same vial of insulin made, or a pen made in the US or France, costs in Europe 1/10 the cost. And you go to India and China, it's only $5 or $10. So why there is so much greed and so much being charged to the Americans, I just don't understand. All the innovation happens here, all the research happens here, and however, Americans end up paying the most. It makes no sense whatsoever.
Well, as you look at these companies, Dr. Garg, and I'm going to probably show my generational distance from our younger generations. But, I used to watch the Schoolhouse Rock, how a bill becomes a law. And I had this idea that, somebody ought to make a similar version of how a drug gets a price. And kind of looking at, the journey that the little drug would go on, through the PBMs, through the insurance companies, from the pharmaceutical manufacturer, et cetera, to kind of look at that different dimension, then the rebates, et cetera. And it's a very confusing journey of that ecosystem of pricing. And I know it's a very big side of it, but I'm just interested in your insights, Dr. Garg, that if you were to kind of look at it, because I think a lot of Americans are just eyes glaze over when they hear about the complexity of drug pricing out in the marketplace, rebates, et cetera. What are the key principles? I mean, that's why I was reading the DLC principles of what they want to keep in place. They're fairly clear, which is if we have a system which is going to be patient-centered, well, then let's make it patient-centered. And let's look at where the dollars hit at that level and build from that around that system. But I'd be interested in whether you think I'm naive. that would be impossible.
No, Steve, I think you said very correctly. Let me take it even a step further. This is a life-saving drug. It needs to be made available, if not free of cost, at a very nominal cost. I gave you an example last time. University of Colorado. If anybody has type 1 or type 2 diabetes, all their drugs or devices, pumps, sensors, insulin, all drugs related to diabetes are given free of cost. Why can't we remove these barriers for people living with the disease? It's not their choice that they got type 1 diabetes or type 2 diabetes. It is an illness they got. We need to remove barriers so that these people can live happily and live a longer, near normal life. That's the barrier we need to remove. Whereas right now, the copays are so huge, $40, $50, $90. Above and beyond, every year, the commercial insurance companies end up changing what they want to pay for. For example, rapid acting, there is a Novolog and a Humalog. Same way on the long-acting, there is Basaglar, Lantus, Levemir, and the Tresiba. I just found out 2 insurance companies stopped paying as of this year, starting in a month ago. Blue Cross Blue Shield and United Healthcare will not pay for any more Tresiba, which is Diglipag, made by Novo Nordisk. They were paying all these years, now they suddenly stopped, which means we have to have our staff go through all the either prior authorization, which I usually know, or give them all the new scripts for the new insulin and find a new dose for the alternate long-acting insulin. That is really not the way system should work.
Fascinating. Cynthia, let me ask you a question. I mean, you've been in this arena for a long time, and you know the terrain well. Congressman Michael Burgess has said that we need to begin thinking about some of these large footprint chronic diseases in America and apply an Operation Warp Speed idea. And in fact, he said that's sort of what was behind the 21st Century Cures Act and things like, artificial pancreas, or I'm getting the terms wrong, and other things like this ought to be higher in the market. But what would be on your wish list of things with an incoming administration should be the high priorities to think about, changing the time curve, if you will, and the treatment curve of diabetes?
No, and 21st Century Cures has made a big difference because research does matter. We do, because of research and the investments in the National Institutes of Health and the work at the Food and Drug Administration, we do have new technologies, artificial pancreas systems, which make it possible for people to get better control of their diabetes. We have multiple versions on the market, and it's a real breakthrough for people with diabetes. But the challenges is making sure people have access to them. And so that's why we're focused so much on making sure that all the actors in the decision maker in the healthcare system, whether it's Medicare or private insurers or the companies themselves, are making these available in real time, without delay, without people having to go through lots of hurdles in order to access these therapies. And so it's critically important that the new administration, continue to fund research, continue to make sure that the Food and Drug Administration is accelerating innovation, and then make sure that people have access. We shouldn't have tens of millions of people still without health insurance or having to pay, extraordinary out-of-pocket costs so that they can't access the coverage that they have. So all of those things are critically important as we move forward.
Thank you for that. Let me ask you both a question, and I genuinely don't know the answer to this because I've talked so much about COVID, the pandemic, what's happening, the disproportionate impact that COVID hits. A lot of the same patterns are exactly the same for diabetes. And Dr. Garg, I'm interested in whether you think COVID has helped raise awareness of the healthcare ecosystem and where diabetes fits in that, and treatment cost reform, or whether it's been a distraction that has harmed the terrain.
No, it definitely has brought to the forefront. I'll tell you why. Because most of the data shows that if you get COVID and you have type 1 or type 2 diabetes, you're at high risk of dying, needing the ventilators, and being in the hospital. One of my patients, unfortunately, had to be in the hospital and was on a ventilator and ECMO for at least 6 months. So it is unfortunate. There is, like this Monday when I saw 14 patients, not a single person didn't ask me about the COVID. What is my risk? What should I do? It has brought to the forefront. Because people are worried about COVID pandemic and the vaccine not being available and therapeutics, we don't know how well they're going to work for people with diabetes. It is so pertinent, Steve, that we need to make telehealth available and be reimbursed at the same level as we are seeing patients in person. In all fairness, majority of the care for people with diabetes, if run through devices like continuous glucose monitors or pump, can be managed remotely, so that out of their 4 traditional visits a year, 3 could be easily reimbursed through telehealth. That'll alleviate patient stress and exposure to coming to the hospitals or to the clinics and be exposed to others for the COVID. And that is the sort of change we need to see. But right now, as I said it about a month ago, many insurance companies are not reimbursing the televisits. So we need to take away the barrier. And to take a step further, Medicare does not reimburse.
Right.
They reimburse the telehealth, but they don't reimburse interpretation of continuous glucose monitor, which is how we are delivering the care. So it's very unfortunate how the piecemeal steps are being taken.
Satish, last time you and I spoke about this, you said the same thing months and months ago. Exactly. I went out and looked at it. It's been the biggest behavioral change, right, in monitoring telehealth, the synthesization of, digital technology to do this. And I can't find a Republican or Democratic member of Congress that's opposed to this. They said, it's been game changers for their constituents. But still, so much of it is going to expire when the emergency of the pandemic is called off, and you're already seeing, business go there. So I'm glad you're underscoring that, and people should know that this world that we've kind of created is, at least right now, officially a temporary one on that. But let me get...
not only that, Steve, also just to add to that, this COVID is not going away.
Right.
It's going to be with us for some time. If we are dreaming that whole population is going to be vaccinated by next spring, we are out of luck. will be
Right.
barely touching the surface. And not only that, a lot of people have delayed showing up for their new onset type 1 diabetes. And if you look at the data, many people ended up going to the ERs with DKA, diabetic ketoacidosis, because they postponed, they were scared of going to the doctors. So we need to make things easier for people.
Thank you. Cynthia, I'm going to give you the last word on this, but as you're responding to the same question, I'd just be interested in whether JRDF is out there trying to underscore the parts of patient health and the dependability, because I know that there's a wobbliness in service as we consider moving from a value-based healthcare system, a wellness-based healthcare system, from a fee-for-service system. There is a wobbliness in that for people. Are you trying to underscore again that we're able to continue to give patients that patient-centric, dependable service they know that they need?
Absolutely, and I endorse what Dr. Garg said about telehealth. It's been a life changer for the diabetes community, and it's important that it continue even after COVID. Look, I think all of these issues, we need change throughout the healthcare system so people can have access to what they need to stay healthy. And we have a very fragmented healthcare system in this country. Right now, employers and health plans and the government can take actions that can help people have access. It's critically important that people with pre-existing conditions, such as type 1 diabetes, continue to be able to get insurance and that pre-existing conditions are protected. It's critically important that people have coverage and that coverage actually covers what they need to stay healthy until research brings us cures for these diseases. So all of the things we talked about today are incredibly important, and we look forward to working with the new Congress. I know later in the program you're going to have two of the leaders of our diabetes caucus on. There is bipartisan support in Congress for both research and access to diabetes therapies, and we made a lot of progress, but we have a lot more to do.
Well, I really appreciate that. I want to thank Cynthia Rice. I'm sorry, go ahead, Satish.
Just one more word.
Sure.
Why can't these Congress people look at what University of Colorado has created for people with type 1 and type 2 diabetes? There are no copay. Diana DeGette knows this very well. Her daughter has type 1 diabetes. So why can't they look at some of these institutes or the big payers who are taking charge of this? Why can't they take that sort of a model?
Satish, since you're helping to open this program today, I'm going to ask Tom Reed and Diana to get that question. So you've already pre-planted it. We'll go to that. But it's always a pleasure to talk to you, Dr. Garg. Dr. Satish Garg, Professor of Medicine and Pediatrics at the Barbara Davis Center for Diabetes at the University of Colorado. Thank you for always taking our call on this. And Cynthia Rice, Chief Mission Strategy Officer of JDRF. Thank you so much for your insights. And I hope that we can keep talking about this subject, but in a way where we begin to track. I always feel like, what have we accomplished with these things? Are we going to be able to track some incremental progress forward? Are we moving in the right direction? And that's what we should be measuring ourselves on. So thank you both so much.
Thank you.
Thank you.
Bye-bye.